Hello, everyone. This is Shad Reis from CVI 2025. I'm really privileged to be with Dr. Brandon Jones to talk about a new, it's still a FDA approved device, or in the process of being
In
approved,
pivotal
for
trials.
pivotal trial for LV reduction in patients with dilated cardiomyopathy. Dr. Jones, thanks for being with us.
Yeah, my pleasure.
Yeah,
Thanks for
so
having
tell
me.
us about this new innovation.
Yeah, so the AccuCinch device, which is made by Ancora Heart, is a device used to treat dilated cardiomyopathy. The clinical trial is ongoing, and this is a transcatheter device that's placed through the femoral artery. You come up through the aorta, across the aortic valve. You then loop underneath the mitral valve, trying to stay clear of the mitral apparatus, and place a series of anchors into the left ventricle, followed by spacers. And at the end of the procedure, you cinch, hence the AccuCinch, and you reduce the LV size. The purpose of the device is an acute LV size reduction, but then what you see in follow-up is that there's a progressive positive reverse remodeling that happens after the acute LV reduction. So it's a very exciting technology. It kind of highlights this overlap now between structural heart specialists like myself and our heart failure colleagues.
Absolutely.
And so the trial just hit its milestone, 250 randomized patients, where we'll be allowed to do our first look at 6-month safety endpoints.
And who are these patients? Like, what are the candidates for this device?
So the patients have dilated cardiomyopathy. The trial would like them to have 2+ or less mitral regurgitation. So they're not targeting mitral regurgitation patients the way a co-op trial would be. And they have to have enough wall thickness to safely place the anchors into the left ventricle, and a large enough femoral artery to satisfy placement of the device.
What is the sheath size?
20 French.
The French. Okay. All right. So you mentioned about delivery, so safety and efficacy has been still in process, right? Or
Yeah,
has been
there's
reported?
data from the original 50 patient early
Pilot.
feasibility, and it showed good signal for safety. There was only one ever reported perforation, pericardial effusion. So, the first thing that came to my mind when you say you're going to put all these anchors through the myocardium is you must cause a lot of pericardial effusions. But fortunately, it's been shown to be very safe. And at least the initial EFS study did show good ongoing improvements in both ejection fraction and reductions in LV volumes out to 24 months. So you get an acute reduction, but then the biological process perpetuates.
Perfect. So when you say 24 French, is it arterial or venous? You come from mitral or the septostomy, or you come from arterial?
I believe it's 20 French. It's an arterial system.
Okay.
So
go to the aorta, come
you
down.
come through the aorta, retrograde through the aortic valve, and then there's this specially shaped catheter that you use to wire in the subvalvular mitral space. So similar to how the M3 device, which is the transcatheter mitral valve, in that case, you go transeptal through the mitral valve, and then you have to get outside the mitral and wrap
I'm trying
around.
to wrap my head around this. Like, how do you get there? Yeah.
It's surprisingly easier when you start from the left ventricular outflow tract. The wire naturally tracks around the LVOT. So it begs the question, will we in the future do something like an M3 from a retro aortic valve approach?
And I'm assuming there's a TEE guided, so you can, as you are pulling back, you're cinching that hole. There's somebody watching the mitral regurgitation too, right?
Yeah, the main purpose of the transesophageal echo is really to ensure that you're behind the mitral apparatus, because if you were to sort of tack the mitral valve open, that would be dangerous. So you're really careful to make sure that you wire around the subvalvular space, and then you're watching for mitral regurgitation as you implant the device, and you're watching for a little bit of aortic regurgitation while you have the catheter across the aortic valve. But it's not a heavy lift from a transesophageal standpoint. The anchors are placed fluoroscopically. So there's this very creative mechanism where a guide wire is placed outside of this penetrating device, and when the guide wire flexes, you know that you're at the correct depth, and then you fire the anchor.
Nice. So again, this is an option for patients who have end-stage heart failure, dilated cardiomyopathy, just before, who are declined from transplant or LVAD?
It actually occupies this space sort of in class 2, class 3, where patients are on 4-pillar GDMT but continue to have symptoms, might have readmissions, and a surprisingly small number of patients actually ever progress on to transplant or LVAD.
So it's literally one step before even you consider that.
Yeah, the idea is that it would be modify the trajectory of the disease to avoid something like an LVAD.
And it has to be dilated cardiomyopathy, non-ischemic cardiomyopathy.
It is both ischemic and non-ischemic
Ischemic, okay.
dilated cardiomyopathy.
That's great. All
Yeah.
right. Well, Dr. Jones, thank you again for introducing this new innovation at Innovations Summit. This is Shad Reis from CVI 2025 in Austin. Dr. Jones, thanks again.